Good afternoon, and thanks for joining us for today's brand new Healthline 3. I'm Courtney Butts, and Healthline 3 is where we like to focus on ways to live a healthier, happier, and pain-free life. We'll be taking your calls and answering your questions live in the studio today. We'll be opening those phone lines in just a little bit, but as a reminder, when you do call, make sure you're in a quiet room with your TV turned all the way down. That number to call is 318-219-4569. Today's topic is rheumatoid arthritis, and joining me today to talk about this is Dr. Robert Goodman, board-certified rheumatologist. Thanks for joining us.
Glad to be here, Courtney.
Absolutely. So rheumatoid arthritis, there's a lot of breakthroughs that have happened in the last couple of years with this. So tell me first, what is this condition?
Well, rheumatoid arthritis is one of our most common autoimmune diseases. And in rheumatoid arthritis, the understanding is that the immune system makes a mistake and behaves as if there's an enemy in the inner lining of the joint and causing inflammation of that inner lining. The name of the inner lining of the joint is called synovium, and we physicians put the suffix itis on the end of a medical word to imply inflammation. So rheumatoid arthritis is a synovitis of the small joints of the hands or feet. We don't know what causes it, but we understand a lot about how it happens and how we can help patients feel better with this disease.
Gotcha. Okay. And so what are some of these symptoms? I mean, assuming that it's generalized maybe to the hands and the feet, is there any pain or?
That's right. It tends to cause inflammation in the small joints of the hands and inflammation in the small joints of the feet, specifically the knuckles of the hands, the wrist, the ankles, the metatarsal bones where our toe connects to the main part of the foot. It can also affect the knee joints and the elbow and hip joints, but the hands and feet are involved in about 85 to 90% of patients with rheumatoid arthritis.
Gotcha. Is there swelling as well that you visibly
There
can
is
see?
swelling that you can visibly see. And we have 14 joints in our left hand and 14 joints in our right hand. So we have 28 joints in the hands, and there is a tool that rheumatologists used called a Disease Activity Score 28, or a DAS 28, now that our viewers know that, in which the doctor would count of those 28 joints, how many are swollen today? And if there are, say, 12 swollen joints, and then they put together some lab tests and some other features and call it, well, your DAS 28 was, you had 12 swollen joints today on September the 19th of 2024, then we would put you on a medication to try to push down on the number of swollen joints and try to be going in the right direction. So if we go from 10 or 12 swollen joints in September, and we drop to 4 swollen joints in October, and then 1 swollen joint in November, we're really going in a good direction to treating and controlling rheumatoid arthritis.
Gotcha. Okay. And earlier in our midday newscast, you mentioned that this is one of the most common forms of autoimmune diseases.
It is. Right up there with it could be psoriatic arthritis and psoriasis. Crohn's disease and ulcerative colitis are very common autoimmune diseases that our gastroenterology colleagues see. But rheumatoid arthritis is right up at the top, especially for rheumatologists.
Gotcha. Okay. And so we were just briefly talking about some treatment options that can help, or kind of introducing medications that maybe people can take. So what are some of those goals when you're thinking about treatment?
Well, we want to diminish that inflammation. So we want to, if we see 12 swollen joints and we can see that those joints are red and warm and tender, and when we move them, it really hurts the patient, and when we touch them, it hurts the patient. What we want to do is control the inflammation. We want to control it so that we prevent joint deformities from happening in a year or two if it's uncontrolled. We want to restore the person to their normal functioning so they can be cooking and doing activities of their everyday life. They can text on the phone. They can have very few swollen joints in their ankles and feet so that they can be a reporter, they can wear heels, and they can stand at the podium and present the news and not have so much pain that it interferes with their activity.
Absolutely. Okay, and so what are some of those steps that you typically maybe set up for clients to achieve those goals?
Well, on the initial visit, you would assess how much inflammation is going on. And rheumatoid arthritis is one of our most common types of arthritis, but there are 100 types of arthritis, with rheumatoid arthritis right at the top. So we want to make sure, get a correct diagnosis of rheumatoid arthritis. Secondly, we want to assess how much inflammation, how many joints are swollen, and then we want to pick a treatment option that would be safe and try to get us to that goal of diminishing the number of swollen joints. Many times insurance requires the rheumatologist to use some generic medicines because they're going to be less expensive, and the most common generic medicine that would be used to treat rheumatoid arthritis is a medicine called methotrexate. Other medicines that are used in that family, a medicine that is an anti-malarial called hydroxychloroquine, and an older medicine called leflutamide, and those are called disease-modifying drugs, or DMARDs. Steroids are also used to treat rheumatoid arthritis early on, but steroids, if you use them for long-term, tend to have side effects, so we want to pivot away from steroids as quickly as we can. If we are treating that person with, for example, methotrexate, and we count the number of swollen joints the first month, and then it's 10 swollen joints, or their disease activity score is very active and very elevated, but we put them on methotrexate and now they're at 7 swollen joints, and then pretty soon they're at 5 or 4. That used to be about as good as we could get in the 1990s. But there has been a revolution in the past 15 or 20 years with the biologic medicines that can be there if a person has an inadequate response to methotrexate, if the number of swollen joints isn't decreasing as quickly as the patient and the physician want. And in the first generation of that biologic group are called biologics that block tumor necrosis factor. One of those biologics is Enbrel, another one is Humira, and there are several other TNF blockers. I would consider those sort of a first generation of biologics, but they are if a person has an inadequate response to methotrexate. The TNF blockers largely dominated the attention of rheumatologists from about 2000 to 2010 or 2012. But what if a TNF blocker quits working? Then you might have to move on to yet some other medications. There are, the nomenclature in immunology is there are communicating proteins between white blood cells. In those communicating proteins, the white blood cells are called leukocytes, and the communicating proteins are called interleukins. So a lot of different interleukins have been approved. Some of them work better for rheumatoid arthritis, some of them may work better for psoriatic arthritis, or even for lupus or other autoimmune diseases. So if the initial generic medicines, the DMARDs, aren't working, you move on to the TNF blockers, and then you might pick other medications if you hold a response for a few months or a few years, and then you start losing that response to one medication. We have a lot of other options that can be brought to the forefront if we have an inadequate response to these medications. And usually we can target almost remission these days. I wouldn't use remission in the 1990s or early 2000s very often, and I would expect to achieve remission in treating rheumatoid arthritis in the pre-biologic era. Maybe 10 or 15% of patients would achieve remission, but as we get these better medications, we can get very close to remission, and that means we have 1 or 0 swollen joints, and we have certain chemical lab tests that mark inflammation. Those lab tests are called the SED rates and the C-reactive proteins, and we see that they are improving as well. We may do images of the joints from time to time to make sure that there's no structural damage. so that we don't get those gnarled, deformed joints that are a permanent deformity.
Right, yes, thanks for explaining that. And as you mentioned, in the 1990s, 2000s, there might not have been many people in remission, but maybe now with all these medications, would you say there's a big difference in what you've seen?
That is, because not every medicine works perfectly in every body, and so now rheumatologists have a lot of different options, and they would treat to target. They would try to target remission or near remission, and if they, for example, go with the initial biologics, they've gone with methotrexate, they go with an initial biologic that is a TNF blocker such as Enbrel and Humira, and by the way, those are medications that have to be given as a shot. And if the person gets to 1 or 2 or 0 swollen joints down from 10 or 14 in their hands, then that patient might stay on those medications for an extended period of time. Some people might be on those medicines for years or decades, as long as it's continuing to work. But then if you lose the response, then we have second and third generation biologics that can be used to treat the patient with rheumatoid arthritis. And more recently, there's a group of medicines that are pills that are used to treat rheumatoid arthritis that are called Janus kinase or JAK inhibitors. And these Janus kinase or JAK inhibitors can be taken by mouth as opposed to taken as an injection. 2 of the JAK inhibitors that are the most commonly used and advertised the most, one is called Xeljanz that came out in 2012, and another one is called Rinvoq that came out just before COVID in the late teens, I believe in 2018 or 2019. And some of those many of these medicines that I'm mentioning for rheumatoid arthritis are also used for psoriatic arthritis as well.
Gotcha. Yeah, these all sound a little familiar, some of those
Exactly.
infomercials that you see on your TV as well. Okay, well, if you're just joining us, our phone lines are open, and that phone number, if you have a question for Dr. Goodman, we're talking about rheumatoid arthritis. That phone number is right there on your screen, 318-219-4569. We'd love to hear from you and ask all your questions specifically about rheumatoid arthritis. Okay, so you mentioned you said maybe 100 different types of arthritis, right?
That's
and
right.
rheumatoid's kind of at the top. So is there ever a time where someone may be confused on which type of arthritis that they have?
Oh, yes, that's very common. And I would say that even us rheumatologists, the tools that we have to separate, say, rheumatoid arthritis from some of these other diseases is not yet perfect. And I have been at some points in my career what is called a principal investigator, which means I'm the one that's doing these double-blind controlled trials. So I would be asked by a pharmaceutical company can you recruit 10 patients or 15 patients in your practice that have rheumatoid arthritis? And I would submit those patients, and then they would send a medication for me to put those patients on, and they might be on, say, methotrexate, and I would be giving the patient an injection that is saline, or 5 or 6 of those 12 people might be randomized to getting a saline injection, and 5 or 6 or 7 of them might be getting active medication, and we would have them on those medications and watch them for about 6 months. I would not know which patients that are on the active medication and which are on the placebo, and the patient would not know who's on the active medicine and who's on the placebo. And that is a classic double-blind controlled trial that is what the NIH insists on and the FDA insists on to try to prove that a medication is good for, say, rheumatoid arthritis or psoriatic arthritis or some of these other diseases. And so I would be counting the swollen joints, counting the tender joints, and then we would be drawing lab tests. We send them in to the central committees that are evaluating the data. We don't know what's going on, but they start seeing patterns. And then at the end of 6 months, they would they would open up, unblind the research, and allow us to have the patients that are not on active medication but are not doing well to get on the active medicine, and then you would continue the clinical trial. Those kinds of trials have been presented for blocking interleukin-6, which is another group of biologics, and those interleukin-6 blockers were approved in the mid-2010 through 2014 range. One of them is called Actemra. It just recently went generic or biosimilar. Another one is called Kevzara. And then, as I also mentioned, the oral pills, the Janus kinase or JAK inhibitors, came along in the early to late 2010s. And so we have lots of different tools to use should we need them if the first generation or the second generation of medicines quits working. And there are some others that I haven't mentioned, but suffice it to say, rheumatologists today have a lot of tools in our toolbox. If one of these groups of medicines is not working, we can move on to a second or a third option. Or if a person is having side effects from one group, you can move on to a second or third group. None of these medicines are perfect, but usually if you can find the strengths of one or the weaknesses of the other in one particular patient, you can usually target near remission.
Awesome, yeah. And so we mentioned remission earlier, but tell me exactly, when is someone considered in that remission status? Well,
remission in rheumatology means they're still on the medicine. Because a lot of times they get off the medication and then the disease comes back in 3 or 4 months. But remission would be if the rheumatologist has, for example, seen 12 swollen joints in the 28 joints that are in my hands, and they go down to 1 or 0 swollen joints. So 11 of the other swollen joints are gone. Their hands look like normal hands, like yours and mine, number one. And number two, if I touch those joints, if I move those joints and they don't hurt the patient at all. Number three, the patient is saying, "Doc, I feel great. I feel like I don't have the disease, my pain," and I say, on a scale from 1 to 10, what's your pain level? And that was an 8 or a 10, with 10 being childbirth, and 0 would be, "Doc, I feel like I'm 0. I feel like I'm 20 years old." Then that is another indication of remission. And then a third one would be to do lab tests that are measuring inflammation, and those lab tests would be, the most common lab tests are something called a sedimentation rate or a SED rate, and another lab test is called a C-reactive protein, and those lab tests would maybe going down to from being 2 or 3 or 4 times the upper limits of normal down to in the normal range, in the middle of the normal range. And so by looking at objective findings of swollen and tender joints, by talking to the patient, and by measuring lab, and also periodically by looking at x-rays and seeing that there's no active x-ray damage, there's no new x-ray damage, the lab tests are going back to normal, the number of swollen and tender joints is going back to 0 or 1, then we're confident that we have remission. We would keep that patient on that medication, or maybe try to withdraw some of those medications or try to decrease the dose, but many times they would remain on that medication.
For life.
Well, for as long as the doctor and the patient feel that it's still appropriate.
Yeah.
And so the patient always has veto power over whether to stay on the medication.
Okay, and so typically these symptoms are, in the joints. Any other symptoms that are maybe associated with mood or that you notice, or is it just kind of in those joints?
Well, yeah, it can be in the small joints of the hands, but it does, and that's 80 or 85% of people with rheumatoid arthritis will have it in the ankles and feet and hands and wrist. But it can affect the elbows. It can affect the knees, and it can affect the shoulders. The number of people that it affects the elbows and knees might be 50%. The shoulders and hips might be 30 or 20%. There's a subset of rheumatoid arthritis that you and I have talked about, called a cousin of rheumatoid arthritis, if you will, called polymyalgia rheumatica, in which the target is more the shoulders and hips,
Okay.
hip disease. And so, but there are also other areas of the body that can be attacked by rheumatoid arthritis, but we don't see those other areas of the body attacked by rheumatoid arthritis today the way we used to see it in the pre-biologic era. Some of those areas are people can get nodules on their elbows or hips that are called nodules on their elbows or knees that are called rheumatoid nodules. Some people can get inflammation in their eyes that is due to rheumatoid eye disease, and occasionally people would get inflammation of the arteries that are throughout the body, and that would be called rheumatoid arthritis causing a arteritis or a vasculitis. Those are usually people who have very poor control of their rheumatoid arthritis, and they're the person that was maybe in the 1990s, and you put them on methotrexate, and they started out with 18 swollen joints, and the methotrexate takes it down to 12 swollen joints, but they still have a lot of inflammation, and the tools, the biologics that are going to come out in 2000 through 2015 are not available yet. And so that inflammation is then causing inflammation in the arteries that is causing rheumatoid vasculitis, inflammation in the eyes that is causing rheumatoid eye disease, and inside the body. And sometimes people could get rheumatoid nodules in their lungs, and then all of a sudden the rheumatologist and the pulmonary doctor are looking at a chest x-ray, it's got a lesion in the lung. Oh my gosh, is this cancer? Is this rheumatoid arthritis? Is this a fungal infection? Is it tuberculosis? And so those outside of the joint, or we would say extra-articular manifestations of rheumatoid arthritis, are fewer and further between. We just don't see them nowadays with our modern treatments. But to go to another point that you're making is the emotional side of rheumatoid arthritis. And in the emotional side of rheumatoid arthritis, for some reason, about 30% of people with rheumatoid arthritis can have what some rheumatologists refer to as non-inflammatory symptoms. That is, we've taken care of all the inflammatory symptoms. Their markers of inflammation are doing great. The number of tender and swollen joints is down to 1 or 0, but they still have other symptoms. They may have depression. They may have other pain that it doesn't seem to be inflammatory pain. They may have non-inflammatory pain, and that needs to be addressed as well. William Osler is called the father of internal medicine. He was the chief of medicine at Johns Hopkins during like 1895 to about 1910, and he would say a good physician treats the disease, a great physician treats the patient who has the disease, and sometimes those emotional parts that go along with rheumatoid arthritis need some attention themselves. And for some reason, about 30% of people with rheumatoid arthritis have those other non-inflammatory manifestations of rheumatoid arthritis. Some of those non-inflammatory manifestations are very similar to fibromyalgia, and so the normal chance of getting fibromyalgia in the general population is 3%. The chance of getting fibromyalgia in the rheumatoid arthritis population is 30%, so it's 10 times greater. Did the inflammatory component trigger this non-inflammatory component? Well, William Osler would say, treat both the inflammatory component and treat this non-inflammatory component. Treat this emotional component. But if you can get the patient back to being very active, if it's a mom with young kids and you can get her back to so that she can take care of her children, you can do a lot to control that emotional, that non-inflammatory component of this disease.
Absolutely, and I think that you mentioned the getting back to being active. I'm sure that boosts your mood, and versus sitting a lot more and not being able to do as much as things like cooking or doing things that you don't normally do.
When you have pain, we have neurotransmitters that then say, oh my God, you just start naturally thinking, am I going to be in a wheelchair? I have 3-year-olds. Am I going to be in a wheelchair when this 3-year-old is in middle school? And so that can be very emotionally taxing, obviously. Or if the husband is saying, well, goodness, I've got that 3-year-old at home. I got to be able to support my family. Or is this rheumatoid arthritis going to prevent me from doing my job as a truck driver, doing my job as a physician, maybe doing my job cutting open coconuts in Hawaii, as we saw Rick Rowe.
Right.
And so if you have to do cooking, or you're a reporter, or if you mow lawns, all of these things. And if you're a surgeon, you might, if you started having compromise of your ability to use your hands,
Right.
grown men, if you want to see a grown man cry, it's a person that has rheumatoid arthritis or psoriatic arthritis, and they're just out of their surgery residency, they're just out of their orthopedic residency. They've invested 12, 14 years to get that training, and now they have this an inflammatory disease of their hands, and their ability to do a surgical procedure might be compromised. Maybe they have so much psoriasis on their hands that they don't feel like they can scrub in. And so I have had some of my colleagues honor me to be their rheumatologists that are other physicians, and we're able to really get control of those things. And as we control that inflammation, whether it's rheumatoid arthritis in the hands, whether it's psoriatic arthritis in the hands, then is your ability to get back to work, as your ability to have less swelling in your knees, less swelling in the metatarsal bones of your feet. That allows you to wear those high heels that you couldn't wear before.
Right, yes, that's a really excellent point. So what are some other treatment options that can be helpful, like physical and occupational therapy? Are those options for these patients?
Those absolutely are. And physical and occupational therapy can be very helpful. Physical therapy, occupational therapy can allow us to find better ways to strengthen our joints. The physical therapist would be often focusing on the walking and ambulation. The occupational therapist would be usually focusing on how to do things with your hands better. So if it's a lower extremity problem, if it's a balance problem, if it's a low back problem, if it's a knee, ankle, and foot problem, the PT guys and gals would be taking the lead. If it is upper extremity, fingers, hands, elbows, how to better use a computer, how to better open a door, how to better cook food and do activities of daily living, it would be the occupational therapist. But we want to try to, because we have better tools to prevent that damage, we don't have to send as many patients to the physical and occupational therapist for late damage. We would be using them early on to try to help restore functionality while we're really controlling the disease itself. And rheumatologists, it's not just me, all over the country have a lot of better tools to really help patients. And so this is sort of a golden era of treating rheumatoid arthritis.
Awesome. Okay, well, we are just about out of time. Thank you, Dr. Goodman, for joining us. Now, if someone has rheumatoid arthritis, are you accepting patients right
I am.
now?
And my office is in Shreveport at 740 Jordan. My phone number is 318-424-9240. That's in Shreveport, 424-9240. I'm at arthdoc.com is our website, and we are on Facebook, Facebook.com/arthdoc.
Awesome. And you see all sorts, you're a rheumatologist, so you see all sorts of autoimmune diseases as well.
That's right. All sorts of autoimmune diseases, whether it's rheumatoid arthritis and psoriatic arthritis and lupus, are sort of in the top tier, but we do see those rare diseases as well.
All right. Well, always a pleasure having you, Dr. Goodman. Thanks for joining us, and thank you for joining us. If you are just now catching the end of this, all of this will be posted on our website at ktbs.com/Healthline3. We also have a podcast, so this will also be posted there, and you can watch that wherever you get your podcasts. Again, thanks for joining us, and we hope you have a wonderful day.